Hello, my name is Dr. Malik Tunc. I'm a first-year resident at St. Joseph Hospital, part of BayCare in Tampa, Florida. Here I'm describing a ventricular mass-induced cardiac arrest secondary to cancer-associated thrombosis. For the case presentation, we have a 68-year-old female with a past medical history of a stage 4 right tonsillar squamous cell carcinoma, first diagnosed in October 2024, as well as a right IJ thrombosis, first diagnosed in December 2024, and she was started on Apixaban. She has received multiple rounds of chemo as well as radiations. She recently had a UTI treated with ciprofloxacin. She came in reporting shortness of breath and weakness, but denied other symptoms. In the ED, she was tachycardic, hypotensive. She had a leukocytosis, hyponatremia, and elevated BNP. She was admitted for septic shock and managed appropriately. Blood cultures grew gram-negative rods. CT of the chest with contrast showed a bilateral subsegmental PE and a right ventricular mass measuring 5.1 by 3.5 centimeters extending into the pulmonary outflow tract, suggestive of a thrombus or a tumor extension. Echo confirmed the findings. Apixaban was switched to heparin, which was further transitioned to bivalirudin, as well as dexamethasone, IVIG, rituximab, and platelet transfusion. Further testing yielded a negative SRA. Cardiac MRI was unobtainable due to severe orthopnea. Cardiothoracic surgery and interventional radiology declined intervention, citing poor surgical candidacy. Transfer to tertiary center was attempted but refused. Patient declined hospice and passed away days later due to cardiac arrest. Multiple rounds of CPR were attempted. Autopsy findings revealed an enlarged heart weighing 490 grams with a right ventricular thrombus, with features of squamous cell carcinoma, positive for P40, CK7, and P16, as well as atypical cells. For our discussion, this case underscores how important managing this type of situations in hospital medicine can be challenging with cancer-associated thrombosis. The right ventricular mass, proven to be a combination of thrombus and tumor, was a difficult diagnostic and therapeutic challenge. The misdiagnosis of HIT further complicated this situation. The consumptive coagulopathy and heart mass formation led to the obstruction of the pulmonary outflow tract. Of note, a prior chest CT from a prior admission a month before did not identify findings of a 3.1 by 1.9 centimeter right ventricular mass appearing as muscle tissue. So here we can go over imaging. So first we have the initial right IJ mass here from December 24. Here in the CT of the chest on initial admission, we have the right ventricular mass occupying half of the right ventricular cavity. And here, from a month prior, at a prior admission, we can see a right ventricular mass forming. So the inability to perform a cardiac MRI was really difficult because we could not really identify the mass further, and the risk to have any invasive procedures or surgery was an evidence. Therefore, here we present the case of cancer-associated thrombosis in the heart as a right ventricular mass. Thank you for listening.